Today I'm only going to touch down upon the episiotomy related anatomy of the same. So this is an image that I love using. This is an amazing image that I have. This has been taken from Berek and Novak. Excellent image. This image has been taken from Berek and Novak is uh, and is given in the chapter of anatomy of vulva and pelvic floor. So whenever I talk about the pelvic floor, this, by the way, is a superficial compartment or the superficial perineal compartment, as I call it. There is a deep compartment as well. I have spoken about it in the genital tract trauma topic because it contains a lot about hematoma and everything. But for now, I need to know only about the superficial compartment. So whenever I talk about the superficial compartment, I have the superficial and deep compartment, of course. So whenever I talk about the superficial compartment, the superficial perineal compartment contains a few things. What are those few things? The few things happen to be, first of all, the erectile body that in continuation forms the clitoris. So the erectile body, which is homologous to the male penis. Apart from that, we have a few muscles that are there. And lastly, we have the vestibular glands, or what we also call as the Bartholin's gland. So over here, you can see now I've only taken the superficial picture of it. Over here, you can see the muscles. What are the important muscles? The first important muscle that you need to see over here is the ischiocavernosus that is present that lines the ischium over here. This area over here. Rather, the inferior pubic rami that goes up to the ischium. So this muscle over here that you can see is my ischiocavernosus. But when it comes to episiotomy, this is not an important muscle. The important muscle is going to be this muscle. This muscle is the bulbocavernosus muscle, very important muscle. And the second most important muscle is going to be the superficial transverse perineum. The third most important muscle is going to be something that you see deep down here, that is the pubococcygeus that is seen just below this. They have not named it over here, but this is the pubococcygeus, rather the part that is slightly above this part, just below this pubic superficial perineum is going to be my pubococcygeus. Now, why do I say it is very important? Before going there, you see that all these muscles are meeting at a common point. This common point is called as the perineal body. This perineal body becomes lax or because of the stretching and because of the episiotomy that you take or the perineal tears that a female sustains with increasing parity or just because of vaginal births. Because of that, this perineal body becomes lax. And if Kegel's exercises, which in my opinion is literally non-existent in our country, there is absolutely no awareness to do Kegel's exercises. But if these Kegel exercises are not done, then the tone of this perineal body is never going to be achieved by the female after her delivery. And because of that, these women are going to develop early onset pelvic organ prolapse. So this perineal body is very important, and whenever you're examining a patient with pelvic organ prolapse, these patients, you often just try to pinch the part near the posterior faucet, and you would see that if it is very thin, then you can also say that this female is going to require reconstruction of this perineal body. So very important is the perineal body. But today, I need to know that whenever I take an episiotomy, which are the parts that are always going to be resected. So I'm going to use a green pen. Ideally, it has to begin. I will show you an evidence-based thing that I have also collected to show you कि angle क्या होना चाहिए. Everything I'm going to teach, but the ideal episiotomy angle, you can take it on either side depending on the laterality. Now, given that I am a right-handed person, I prefer to take, I hold the episiotomy scissors like this. I don't hold it, I don't cut it like this. I cut it in this direction because of the episiotomy scissor का direction. I cut it in this way. The पीछे का जो side है. So basically for me, the maternal left side is where I will be taking an incision, but you can take it on either side. There is no such rule. The more important part is I take a medial-lateral episiotomy. I'm going to be teaching about every single type of episiotomy. And the muscles that are going to be transected are, so the most important muscle that is resected is going to be the superficial transverse perineum, secondly the bulbocavernosus, and if you end up taking a premature episiotomy or if you take an episiotomy when the perineum is very thick, you might also end up extending a bit into the pubococcygeus. You cannot definitely make out कि ये muscle है, वो दूसरा muscle है. It is literally a complex of all the muscles given that you're very close to your perineal body, so all of them are going to meet there. But these are the three muscles, the most important being the superficial transverse perineum. second being your bulbocavernosus, and third being your pubococcyges that are resected during your episiotomy. Usually the pubococcyges is not going to be resected if you follow the proper rules and guidelines of taking an episiotomy. But before coming there, what is an episiotomy? So episiotomy is nothing but an iatrogenic or a surgeon-induced perineal tear or a perineal incision. Incision is something that I would rather use for something that a blade makes, so I can also use a perineal cut as a word for episiotomy. Episiotomy is often made with an episiotomy scissors. Your episiotomy scissors are something that are going to look like this. They'll be looking like this. They are going to classically look like these, but you can even use your usual stout scissors that are straight scissors and give it. This is something that I prefer to use. I'll be holding it this way in the opposite direction. A few people even hold it in the direct direction, like facing this tip. I prefer this tip going out from my body, whereas a few people also prefer to put that episiotomy with the apex of this scissor facing towards the palm of their hand. Either way, it is okay, but this is a specialized episiotomy scissor. But if it is not available, you can even use a simple Metzgerbaum or stout scissors that are available in your labor ward. With this, I'm going to take an episiotomy, and an episiotomy is technically a grade 1 and 2 tear. So when I talk about grade 1 and 2 tear, which are these grades and what is the classification? This classification is called as a Sultan's classification. But before going for Sultan's classification, there is something that I would want to show you. This something is basically a picture from the RCOG guidelines. And in those RCOG guidelines, they have given a perfect mention of how and where exactly. So this is a guideline picture that I have taken. So ideally, they say that you should try to take an episiotomy whenever there is crowning that is achieved, but a lot of times the crowning is not waited upon. A lot of people end up giving it prematurely. But ideally, you should be waiting for the crowning to occur. Crowning is basically the head when it is separating the labia majora, and the labia minora by itself. You don't have to separate the labia with your fingers. The head is doing it by itself. That is called as crowning. So basically, the labia is sitting on the top of the head like a crown, and the head is visible by itself from the perineum. That is when the perineum is thinned out maximally, and you can ensure that you're only giving out a very thin episiotomy. By thin, I intend to say you wouldn't go till the pubococcyges. So an episiotomy that is performed at a degree of 40 degrees. So what is this 40 degree that they're speaking about? So if this is my labia majora and if this is my rectum over here, so if an episiotomy, this is my central axis. So if it is performed at an angle of 40 degrees, this is an angle of 40 degree, then they say because of the stretching of this vulva, because of the stretching of this perineum by the head of the fetus, once the head is delivered, the perineum is no longer going to be stretched, so it is going to come back to its original position. So if during that stretching period, you end up giving an episiotomy at an angle of 40 degree, then once the stretching is gone after the baby is delivered, you are going to have an angle of just 22 degrees. So 22 degrees is going to be like this, and this angle is very close or is directly almost going near the anal opening, which is why they say that this is too close to the midline. And I wouldn't really want to be doing so much, because if it gets extended, then it can even go up to the anal mucosa. So they say that ideally you should be taking at an angle of 60 degree, because once you are done, the post delivery angle is going to be of 45 degrees. So what they recommend is, if this is my vulva or the labia rather, and this is my rectum, then the ideal angle should be 60 degrees from midline. This became a little too much. Should be this much, around 60 degree, because after that stretching is gone, it will lead to an angle of around 45 degree, and 45 degree is acceptable because it will invariably end up bypassing the anal opening, which is why the ideal angle in which you should be giving the angle should be with respect to this midline, the line that joins the posterior faucet to the center of the anal opening. Uske hisab se wo angle lena hai. The angle should not be taken from a transverse line, it should be taken from the midline that connects the posterior faucet to the anal opening, and 60-degree angle is the correct angle. So special scissors have been designed to ensure that an angle of 60 degree, which have been shown to be achieving the correct angle. So they often, ये जो angle होता है इसका, ये भी काफी बार 60 डिग्री का ही रहता है. So this is how ideally an episiotomy should be taken. So now that I've mentioned about medial and mediolateral, what are the various types of episiotomy? So whenever I talk about the episiotomies, the simplest type is going to be a median episiotomy. A median is the one that I take on the midline. After that, I'm going to have something that I call as the modified median. After that, I'm going to have something that we call as the J type. Then we have mediolateral episiotomy. It can be on the right, it can be on the left, it doesn't matter. Or you can have something that we call as a radical lateral. This radical lateral is also called as a Schudart incision. This Schudart incision is usually not required in obstetrics, and it has a bigger use in post-menopausal women whenever you are trying to remove any cervical mass, or whenever you are trying to do a vaginal hysterectomy, a non-descent vaginal hysterectomy, but the vulvovaginal mucosa has become sclerosed because of menopausal changes to it. So to increase that, you'll be taking, I'll be showing how it looks like. But these are the various types of episiotomies that can be given. Of course, the one that we use is a mediolateral one, but before that, we would also want to learn about all of them. So the median one is going to be the episiotomy. If this is my vaginal opening introitus and if this is my rectum, the median one is going to be either in this direction or plus minus 25 degree. So 25 degree यहाँ पे, 25 degree यहाँ पे, within these 50 degree अगर कुछ भी हो, it is going to be called as a median or midline episiotomy. Of course, it is not preferred anymore because it is going to, if there are any extensions, then they will directly go into the anal mucosa and lead to a grade 4 perineal tear. Often, the perineal tears that are sustained while delivering fetuses, wherein you have forgotten to give an episiotomy or wherein the baby has just come out too rapidly and you couldn't give an episiotomy, are going to be often in this direction. Of course, you wouldn't call it an episiotomy because you have not given them. Those are perineal tears that are sustained accidentally. So episiotomy is when you are yourself using the scissor to give this kind of a tear. It is not preferred given its direct direction of point or its direction that is going directly into the anal mucosa and the anal opening. The next is a modified median. In modified median, they say that you take a median episiotomy, but you go 2.5 centimeter on each side. So 2.5 over here, 2.5 over here, so that you do not go downwards and you also end up creating a proper flap and you can deliver it. Now, the problem with this is that if you're going to start going laterally, you end up going into your pubococcygeus. And not just pubococcygeus, you're also going to go towards the gluteus maximus, and let alone that, you're going to give rise to multiple bleeders and a very poor outcome. The female is going to have a lot of pain while sitting, which is why this is not preferred, but this is modified median. To encounter that, the next episiotomy that you have is going to be a J-shaped episiotomy, wherein you do take median, but then you go either on this side or on the other side. The side will vary, but this ensures that you are not going towards the rectum, nor are you taking this straight out transverse incision. The next one is what we usually take, and that is 60 degrees to midline on either side. You either take it on the right side or take it on the left side, definitely not both, which is going to be at an angle of 60 degree from the median. This is the one that you prefer the most. The last one is a Schudart incision. It is going to be, you just don't take any episiotomy downwards. Instead, you just go on both the sides like this. Now, this is done, as I said, whenever you have a fibrosed mucosa or fibrosed vulvovaginal opening and you're unable to reach out to the specimen, you are unable to take your sutures inside whenever you're taking the pedicles of vaginal hysterectomy. At that point, you can take this Schudart incision so that your vaginal opening increases and you can deliver the specimen by applying clamps comfortably. Since I've mentioned this to be the Schudart incision, can someone tell me what is the name of that incision that I take on a cervix whenever there is any possibility of the baby being entrapped, or if the cervix is not dilating enough? What is the name of that incision? You'll tell me in the chat. Hmm, Prathamesh, pathetic spelling. Drusen क्या है? And Sindhu, Durance क्या है? In fact, if we combine ये दोनों answers, then you would get the answer. It is Derson's incision. Derson's. So दोनों को combine अगर spelling करोगे तो तुम लोग का actual answer आएगा. But yeah, you both were close. Since you have anyway mentioned this or you have answered this, could you just also tell me what is the angle at which you give it? What is the location wherein you give that Derson's incision? And what is the reason behind it? Quickly tell me. Quickly type करो और मेरे को बताओ. By the way, who do we have today with us? We have Shalini, we have Priyam, we have Prathamesh, of course, we have Sonika. Hi, Sonika. Hi, Suman, and we have Nandan as well. Angel Nandan. I hope your name is not Angel. And yeah, Aishwarya. So, hi everyone, and tell me the location at which we'll be taking. 2 o'clock, less blood loss. Very close. So, I can either take it at 2 o'clock or I can take it at 10 o'clock. The reason is that at 3 and 9, there are going to be the descending cervical branches. Descending cervical branches जो basically ऊपर जाता है तो ascending uterine बनता है जो तुम लोग cesarean section में लेते हो या फिर you can take it, yeah, 6, good evening, Sonika. Yeah, 6 o'clock is also a good location, but we usually prefer to take it at 2 or 10 because we have to bypass or we have to be away from 3 and 9 location जहां पे descending cervical का branch आता है. Now that I've anyway spoken about descending cervical, could you all also tell me which is that one specific surgery where I ligate the descending cervical artery? Tell me the name of the procedure. Until then, I'll proceed with my session. Which is that one specific surgery where I very specifically ligate the descending cervical. I've taught this in one of my previous sessions. Anyway, so these were all the various types of episiotomies that are possible and the literature that suggests that it should be taken at 60° to midline. Now I have taken an episiotomy, and once the episiotomy is taken, of course, there has to be a certain grade up to which I take it. And if I'm not taking it adequately, and if there are tears that are occurring much more than my intention, what do I call them? So this has been given by Sultan under the Sultan's classification. So has anyone answered? Modified Fothergill. Excellent answer, Prathamesh. Not modified. There is nothing like modified Fothergill. I've never heard of this. It is Manchester Fothergill. There is no modification to it. Shirodkar modified it, yes, but it is overall called as Manchester Fothergill only till today. The modification was the uterosacral ligaments were advanced. That is Shirodkar's modification, but you still call it Manchester Fothergill. But yes, that's the right answer. You take descending cervical so that the neocervix doesn't bleed before you ampute the cervix off. Good answer. And Ashokanand 2 suture, no. Ashokanand suture, I very honestly do not know what is this Ashokanand 2 suture. I've only heard of one Ashokanand suture, that is A suture. And in that A suture as well, you take the suture around all the collaterals of uterine artery. So basically, it is a type of uterine artery ligature, but in a way that you cover all the collaterals that are present near the lower segment. You do not go down till the level of your cervix to take descending cervical, because if you are going to ligate the descending cervical, how will it stop the bleeding that is occurring in the uterus? It is logical. You have to stop the uterine bleeding, which is why the Ashokaran sutures are to be taken on all the collateral branches of your uterine artery. Uterine artery is basically the ascending counterpart of the descending cervical. Okay. Both, of course, coming from the anterior branch of internal iliac. Transvaginal uterine artery ligation for PPH. Baap re. Transvaginal uterine artery ligation for PPH. I have never in my life heard of this. Transvaginally मैं uterine artery तक कैसे पहुंचूंगा? No, do not even attempt to do that. Very dangerous thing that whatever you are suggesting, transvaginal uterine artery ligation. Terrible idea to do it. And in other words, अगर इतना ज़्यादा bleeding हो रहा है, I would just want to explore her and abdominally try to take internal iliac artery, anterior branch of internal iliac, but do not go for all these transvaginal uterine artery ligations. Very dangerous thing to be done. Also remember that transvaginal uterine artery ligation is only going to help in traumatic postpartum hemorrhage of your cervical tear. It is not going to help in any other form of postpartum hemorrhage. So it is almost pointless for you to do that procedure vaginally. You can just do it abdominally.